Hi, my name is Kara Gillum, and I'm a physical therapist at The Ohio State University. And I performed this case study during my neurologic physical therapy residency. But along with myself, Meredith Banos, my residency mentor, and then Emily Poloff, who was her student at the time, completed this case study. I have no disclosures, and participant consent was obtained before any of the videos included in this presentation were performed. The participant for this case study was a 42-year-old male with a past medical history of incomplete traumatic spinal cord injury at the cauda equina level in 2007. He since then had recovered ambulation with various assistive devices for the following 10 years. However, in the last 2 years, he demonstrated a decline in function and then became no longer ambulatory just before admission. His acute diagnosis for whenever I saw him in the inpatient rehab facility was incomplete paraplegia at the T3, T4 level, and he'd had laminectomies for removal of an intradural extramedullary tumor. At the time of evaluation, he had impaired light touch sensation below the T4 level and paraparesis in bilateral lower extremities. You can see the strength assessment there in the chart, and as you can see, he had a little bit more activation distally on the left, but proximally on the right, and so significantly impaired strength in bilateral lower extremities. Here you can see in the ICF model his body structure and function impairments was the impaired sensation, weakness, and balance impairments in sitting, as well as his inability to stand. Activity, he wasn't able to ambulate. He required contact guard assistance for sitting balance and transfers with use of a slide board. He also required moderate assistance for bed mobility and was unable to stand at time of evaluation. Therefore, his participation restrictions included his inability to participate in sports and other activities with his kids, and he was unable to work. Environmentally, he had no equipment limitations. He had acquired a multitude of variety of assistive devices and equipment over the last 10 plus years from his prior injury. And he also was very motivated. He'd self-rehabbed since his initial traumatic spinal cord injury. So he was very motivated to return to his prior level of function and had very good family support. From an intervention standpoint, we decided to incorporate both neurorecovery network principles for optimizing his ambulation and locomotor training, but we also wanted to utilize the major components of the new Locomotor CPG for chronic spinal cord injury, traumatic brain injury, and stroke. So even though he had an acute injury, since he had that prior traumatic spinal cord injury, we decided that we would implement the Locomotor CPG, but then we were considering those neurorecovery principles as well and how to optimize his function prior to discharge. We did have some barriers throughout the plan of care, additional comorbidities and illness, which are very common in the inpatient rehab setting. Also, just education and health literacy on a non-traumatic versus traumatic spinal cord injury, recovery, optimizing function, and just safety concerns. Then again, trying to optimize a balance between neurorecovery versus compensatory strategies to maximize his independence upon discharge, and then institutional thoughts and beliefs on which one of these approaches might be most beneficial for the patient. The intervention that we utilized included the FIMP principle for incorporating intensity, such as the Locomotor CPG recommends. So we tried to focus on 5 days a week since we were in inpatient rehab. Intensity was between 60 and 85% heart rate max, and you can see his correlating heart rates there based on age predicted max heart rate. We did really want to get him at the higher intensity though. I included ranges from 60 to 85% because that's where we calculated using our heart rate monitor how long he was in that range, but we wanted him to be in that high intensity range as much as possible. The time, he had 90-minute sessions every day for those 5 days a week, and then we wanted to be in that high intensity heart rate range for 20 to 30 minutes a day. And we utilized gait, strength, balance training in order to achieve these goals and his inpatient rehab goals. And again, balance was for more transfer training, functional training, not for translation to gait improvement. We initially started with treadmill walking, and we did this because we could control the environment. We could help with lower extremity advancement since he had significant weakness in bilateral low extremities, but also support his trunk for safety. We initially started with lower body weight support, but we did not see his heart rate max increase into that high intensity range. It was still high, but just barely in that moderate intensity range at about 65%. And then we tried to decrease his upper extremity support, and however, we thought that his max heart rate would increase, but it actually decreased compared to whenever he had the upper extremity support. So for example, you can see here he achieved 78% heart rate max with bilateral upper extremity support, but only 75 without upper extremity support. And again, that's still in your moderate intensity, edging over the high intensity heart rate range, but because he could tolerate that high intensity training and we wanted to make as much progress as possible, we wanted to keep him in that high intensity range. And again, the participant really wanted to return to walking as soon as he could. Since he'd had that decline in function, he wanted to get back where he was before. So that's why we tried to focus on the high intensity training as much as we could. Here you can see when we started on the treadmill with upper extremity support, assistance at bilateral lower extremities, and assistance at the trunk for safety and stability. He achieved 76% of his heart rate max at the maximal heart rate during the session, but he maintained a range of 50 to 76% heart rate max for most of the session, about 80% of the session. He did require 25 to 45% body weight support to achieve that though. And here you can see we were trying to progress to no upper extremity support, needed more assistance at the lower extremities and trunk in order to achieve that. And he achieved 60 to 70% heart rate max, greater than 50% of the session, but he required a lot more body weight support, 45 to 50%, and he didn't achieve as high of a max heart rate. Here you can see him ambulating while we decreased the body weight support, and he only achieved 65% of the heart rate max, whereas he achieved in the 70s in the last two scenarios. So he used his upper extremities here, had decreased body weight support. We tried to get away from upper extremity support, but he really needed it with that less body weight support, and he was only within that moderate intensity range. He required still 30 to 45% body weight support. So then when we saw this during the session, we still weren't getting that heart rate as high as we wanted to, so we progressed to overground gait training within this same session. So our goal with overground walking, because his goals were to walk overground once he left the inpatient rehab facility, and we knew he was going to be doing a lot of his rehab on his own at home since he had equipment available, we really decided to progress overground, and even if it required some compensation, we did this to focus on intensity and for that carryover to home. We didn't achieve the highest heart rate that we wanted to with treadmill training, even while optimizing kinematics. So when we progressed to overground training, we tried to decrease the body weight support and the physical assistance that he required, added in resisted walking, changing directions, increase the distance of the gait bout and speed of gait in order to continue to challenge intensity in a less structured environment. Here you can see first session of overground walking, only required 10% body weight support, and he achieved 89% of his heart rate max. He looks a lot more stable too. He was walking significantly slower than on the treadmill since he was controlling that gait speed, but he was doing a lot more of the ambulation on his own, required a lot less assistance, and his heart rate was a lot higher. We then progressed to use of a passive harness, so there was no body weight support assistance with this harness. And again, he was performing a lot more work, required less assistance with the lower extremities as he progressed.
You're gonna try to get there, huh?
And he achieved 97% of his heart rate max. And you can see in that chart there, he was in that 60% or higher heart rate max for 90% of the session. And then here you can see a translation to overground without use of a harness once it was safe. And this was right at the end of his rehab stay. Again, doing a lot more on his own than he was with use of the treadmill and the harness.
Go.
Here were some of the progressions for overground training that we did.
Go, go, go.
You can see resisted walking
Old man speed.
to, again, focus on keeping that intensity up. And we also did backwards as well, which was really, really challenging for him.
Faster, faster.
And he achieved 96% of his heart rate max with these progressions. And during this whole session, he also maintained between 65 and 96% of his heart rate max for the whole session, all except for a few minutes here at the end.
The resistance.
And then we also did some sideways walking to work on change of direction. And for the session, whenever he didn't have the harness on, he achieved 89% of his heart rate max for 60 to 80% heart rate max for over 89% of the session. In terms of functional strengthening, the Locomotor CPG has this as a may consider category, and we utilized this focus in order to optimize transfers, seated balance, but not specifically for translation to gait. And it's a may consider category in terms of translation to gait training and locomotor training. So we incorporated this more for those functional goals outside of ambulation to maximize his independence as well. We also did decide to incorporate that high intensity focus while we were doing these activities though. So that's where we kind of incorporated part of the CPG into this training, even though it wasn't as much for translation to gait. For functional strengthening, we did try to focus a lot on some standing balance and core stability, trunk extensor, core strengthening and balance again, and with that intensity focus. So you can see here we worked on some standing balance interventions. And during this session, he obtained 86% of his heart rate max, even though we were not ambulating. We also maintained the target heart rate range for about 98% of the session. In this middle video, you can see us working on trunk extensors. And he achieved 60 to 70% of his heart rate max during this activity, and more mat level strengthening.
There you go.
And then in the final video, we were focusing on core stability, balance, more for that translation again to transfers. You can still see that we did achieve moderate to high intensity with these interventions. Again, some more functional strengthening. This time we utilized FES for more of those standing interventions, lower extremity strengthening to give him a little bit more stability. You can see the progression of his standing balance with some upper extremity tasks, decreased upper extremity support reliance, and also we worked on sit to stand transfers. And you can see he was in that 60 to 80% heart rate max range, so more mod intensity for about 80% of the session. Here's just looking at our goal fit principle and then what we actually achieved. So again, these numbers include moderate and high intensity time that was spent in those ranges. And so we did achieve at least 30 minutes in that intensity range for each session that we were tracking his heart rate and trying to focus and implement those intensity principles. And again, you can see his heart rate range there, what our goal was. But we also did achieve over that 85% in multiple sessions. Here you can see how his heart rate ranges correlated with the specific activities we performed. So his highest heart rate was during overground gait training without body weight support, so either the passive harness or no harness, and whenever we were not optimizing kinematics. So we were just providing the assistance he needed to perform the activity safely rather than focusing on the specific neurorecovery principles. Also, his heart rate maintained within the heart rate range that we included in our FIT principle with high intensity interventions that were for strength and balance training. So not just the locomotor training interventions, but also strength and balance interventions that we utilized as well. Here you can see the outcomes from admission to discharge. So we did perform the Berg and a 10-meter just because they are highly recommended for neurologic diagnoses. However, he did not have much of a change there because he wasn't able to stand on his own. So he did have the improvement in seated balance that got him some scores, some score improvement upon discharge. With the 10-meter, he did improve his gait speed. He doubled it almost, but still a very, very slow speed and not a functional ambulation speed. For specific activities, his seated balance, he initially required upper extremity support, contact guard assistance, and at discharge he was independent without upper extremity support. For transfers, upon discharge, he was independent with modified stand pivot and uneven slide board transfers. And then for sit to stand, he required min to mod assistance with use of a two-wheeled walker upon discharge. And then for bodyweight support treadmill training, I included some of the distances that he was able to complete on the treadmill versus overground just to see the progress during his plan of care. So initially, he required quite a bit of bodyweight support, and he was able to achieve distances over 1,000 feet per session whenever we gave him that much bodyweight support and physical assistance, but in 200 to 300 foot bouts. And then overground, his max distance was 70 feet with 10% bodyweight support and 30 to 50 feet consistently without any bodyweight support. And he totaled over 100 feet per session, but again in those smaller bouts. Some of the barriers, again, that we had during the plan of care. Initially, he required a lot of hands-on assistance early in order to just keep him safe and to optimize those kinematics that we were trying to achieve early on. We also provided lots of educational handouts and interview in order to optimize recovery and independence upon discharge. We utilized a variety of interventions in order to kind of trial and error what was the best approach for maximizing safety, but also intensity and neurorecovery and independence upon discharge, both with strength, balance, and gait training. And then modifying the setup of interventions to provide appropriate feedback for the patient to achieve the targeted movement, such as use of mirrors or demonstration using FES, and then providing him feedback on heart rate and intensity as well. Here you can see changes over time. So improvements in the hip core strength and stability, less reliance on upper extremity support. Improvements in gait speed and ambulation with less assistance. Improved activation of his hip extensors, flexors. And then progression again to ambulation without use of a harness or bodyweight support. And decreased assistance overall. Some major takeaways. We did achieve the target heart rate range while we were on the treadmill, but we were minimally within that range, and even though he was working hard, we weren't getting the benefit and carryover that we wanted to maximize his independence upon return home. So we trialed some of those strategies that we thought would increase his intensity and found some differences from maybe what we were hypothesizing. And so the importance of tracking heart rate and RPE throughout in order to see how hard that he actually was working, even if he required a lot of assistance. So we did also just find a lot of trial and error with trying to balance those neurorecovery principles with high intensity training to maximize recovery. And again, the route that we went with this patient isn't necessarily what would work best for everybody, but since he was really motivated to make as much progress as he could while he was with us, and was going to be primarily self-rehabbing once he got home, we thought this was the best route for him versus focusing on mechanics. Again, the parameters that promoted greatest heart rate demand for this patient were resistance, speed, less body weight support, decreased physical assistance, but still utilization of upper extremity support, and then performing multi-directional gait in order to, again, progress that resistance and intensity. And again, just considering that functional strengthening interventions might be considered and might be appropriate in order to progress transfer and ADL training when gait training isn't possible, or you maybe aren't able to do that one day based on equipment or illness or anything that could be going on, but that you can still implement those intensity principles to these other interventions as well. And here are my references. Thank you.